الرحمن الرحيم قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. So we start with the ventilation and a series of lectures which are related to ventilation. There are 7 actually. Should be anatomy and physiology of respiratory system. We have done that to some extent. Then mechanical ventilation with general aspect, including the indication for intubation, indication for ventilation, and indication for extubation. Then third was the physiology of ventilation. This we did last time. Now, how to start the ventilation is the lecture which I will be delivering today. Then monitoring during ventilation. This is a full topic. This might take 2 lectures. Then non-invasive ventilation. Then is discontinuation of ventilation. You have put the patient on ventilator. How to discontinue the ventilation? How to take the patient off the ventilation? In other words, how to wean the patient off the ventilator. Now, I was just saying today, discussing this one, the first positive pressure ventilation, when did it start? So this is a quote from the Bible. It dates back to creation of humans. When the human beings were made, in the Bible it is written, and the Lord God formed man of the dust of the ground, and breathed through his nostril the breath of life, and the man became a living soul. हज़रत आदम अलैहिस्सलाम का जब बुत बनाया, उन्होंने पुतला बनाया और उस पर आगे नाक में फूंक मारी और उससे उन्होंने सांस लेना शुरू कर दिया. That is the first, in a historic way, that is the first human being who was put on a positive pressure ventilation or who was given positive pressure ventilation. Now, as far as the ventilators are concerned, in the first lecture we actually classified also. Now, there are 3 types of basic principles of ventilators. One is a pressure generator, other is a flow generator, and third, they have got the combined technology by the company who make them. Now, basic principles of operation is there will be inspiratory phase, then there will be inspiratory to expiratory cycling, then from expiratory phase, then from expiratory to inspiratory cycling. There are 4 phases this way. So first inspiration period, then ventilator turns it, stops inspiration, and expiration starts. Once the expiration is finished, then again the inspiration starts. This is called cycling from inspiration to expiration, then from expiration to inspiration. This is automatically done by the ventilator. But there are basic principles. Now, inspiratory phase could be pressure generated and could be flow generated. The ventilator is pushing the gases under the pressure or giving the flow. So there is a difference between volume and a flow. Physics, according to physics law. Now both are unaltered by the patient's characteristics. Then inspiratory to expiratory cycling. It could be time cycling. You set the time that after certain second the inspiration should stop and the expiration should start. Or it could be volume cycle. If predetermined volume has gone into the lung, then the inspiration automatically stops and the expiration starts. Or it could be pressure cycling. If the gases which are pushed into the lung under certain pressure, if it reaches up to certain pressure, then automatically expiration should start. Then flow cycling. When the flow is reached up to certain level, then the inspiration stops and the expiration starts. So very simple thing. These are automatically learned by the ventilator. You have to choose only the mode, that whether you are giving a pressure mode or volume control mode. Then from expiration phase, it is analogous to the inspiration, and this will be 2 types, pressure generator and volume generator. 2 types of cycling. Then from expiration to inspiration again, it is a time cycling or pressure cycling. So you have got these options in the ventilator already built in. Now, when you put the patient on a ventilator, what information is required before you put the patient on a ventilator? The first thing is mode of ventilation. You should know what type of mode I'm going to put the patient on, whether it is a pressure control mode or a volume control mode. So it should be in your mind first. You should have decided according to pathological condition of the patient. Then, what should be the inflation volume? You should have calculated already the volume which is required for this particular patient, for this particular lung. So you should have calculated already and kept it, whether you are giving through the pressure generator or whether you are giving through the volume control. Then third thing is the respiratory rate. At what rate you are going to ventilate? 12 per minute, 20 per minute, or 15 per minute? You should have already decided according to already present parameters or blood gas levels. Then inspired oxygen level. What percentage of oxygen you are going to give? Are you going to ventilate on 30%, 40%, 50%? So this should be in your mind. Whole things should be mind. One is a mode of ventilation, second is a volume of ventilation, third is a respiratory rate, and the fourth is FiO2, fractional inspired oxygen concentration. Now, mode of ventilation, as you already know, the control modes are two: pressure control and volume control. Then there are assist modes like BiPAP, IMV, MMV, SIMV, and there are so many others also. I've just mentioned the name. So these are the assist modes, but actual modes are two: volume control and pressure control. Now you're going to any inflation volume. You calculate the volume according to the ideal body weight. It's very difficult to calculate the ideal body weight. We were just discussing yesterday evening. Ideal body weight, there are so many people have given so many formulas to calculate the ideal body weight. You just take simple body weight. Initially, we put a little bit on the higher volume, 8 to 10 mils per kilogram of ideal weight per kilogram of body weight. So if the person is 70 kilogram, suppose you want to put on 8 mil, so it should be 70 into 8. So that should be the volume, that is your targeted volume. You think that this should be adequate volume for this particular patient in this particular condition. Then later on we reduce or increase the volume according to the response, which response is on the blood gases. According to the blood gas report and according to the mechanical inflation of the lung, so you change the volume. First of all, you put 8 to 10 mils per kilogram body weight. So that should be the first one when you put the patient on there. Then consider compliance of the connected tubing also. Now the tubing through which you are ventilating, or ventilator is delivering its gases to the patient through the tubing. It has got inspiratory limb, it has got expiratory limb, then you got a filter, catheter mount and filter, and then you got the tube which is going into the lung. So this tubing, when the ventilator pushes the gas under pressure or under volume, this tube expands. That's called the compliance of a tubing. What compliance is nothing, volume change per unit change in pressure. As the gases are coming under pressure, so it will expand and some of the volume of gases will be accommodated over there. That should be considered also. It's about 3 to 4 mil per centimeter of water peak inflation pressure. The pressure which is shown on the ventilator, that is the peak inspiratory pressure. And for example, it is giving 15. 15, you are giving 3 to 4 mil. Say 4 mil is its compliance. 4 into 15. 60 mils is already whatsoever volume you have adjusted is accommodated in the circuit. So that's why you give a little bit higher tidal volume in the beginning to ventilate your lung. So you must always keep in your mind this compliance of the tubing, inspiratory limb of the tubing through which you are delivering the gases to the patient. It sounds simple, but it sounds just like that. We will ignore it, but it should not be ignored. It should be kept in mind. that there is a compliance of tubing. So whenever you buy a tube, inspiratory or expiratory circuit with which you are connecting with the ventilator, you must look at the tubing also and the specification of the tubing. It must be written on those tubing what is the compliance of those tubing. So then that is a standard circuit. जो circuit पे डालते हैं उसका पता होना चाहिए आपको कि इसकी compliance कितनी है. उस लिहाज से आप tidal volume को adjust करते हैं. कभी आपने किया ऐसे? क्यों जी? बड़ी अच्छी बात. तो इसको that will be accommodated by the tubing. Where tube expands, आप देखें जरा गौर से, during inspiration it expands, and during expiration the gases are going passively. So these things should be kept in mind. Rate, initially we start at 12 to 14 breaths per minute. Then later, according to the blood gas response, according to the ABG, we can increase or decrease the respiratory rate. That you look at the ABG. ABG means you look at the pH, you look at the PCO2, and you look at the bicarbonate. These are only three things they will decide whether to increase the rate or decrease the rate. And out of these three things, most important is PCO2. That will guide you. FiO2. When you put the patient, you start putting the patient on is you put on 80% or above. It doesn't matter what is the pathology of lung. You start with 80%, then you decrease 10 to 20% every 20 minutes till you get the desired PaO2, partial pressure of oxygen in the blood, right? So you adjust the rate 12 to 14, you give FiO2 80%, and it's written 0.8 also. 80% means 0.8. 0.8 out of 1. So then you increase or decrease according to the response on the partial pressure of oxygen in the blood, arterial blood, right? So you have adjusted the mode, you have adjusted the respiratory rate, you have adjusted the FiO2. Now ventilator modes, volume targeted or the pressure targeted. As we say, volume controlled or pressure controlled. In my opinion, people have written so many things. In my opinion, and according to my experience, every patient should be put on the volume control to start with. Whenever you put the patient on a ventilator, you choose the volume control. Then once the patient is adjusted for 20 minutes or half an hour, then you change the mode as per condition, pathological condition of the lung. In simple, I can say, any intracranial problem, the patient should be put on the volume control. Patient with COPD and asthma patient, they should be put on volume control, not on a pressure control. Then the rest of the patient, we put them on a pressure control unless there is a contraindication to it. So this is roughly which we kept. If there is a brain insult, we always put on the volume control. If there is COPD or asthma, we put them on a volume control. The rest of the patient put on pressure control. But initially, we put on volume. Once everything is settled, then you start with the specific mode, which mode you want to give. Now, in volume control, there are choices. Simple volume controlled ventilation. It is mandatory. It means all the breaths has to be pushed in by the ventilator. Patient should not be breathing. Then inflation is the time cycled, is the timed. So with a certain time of period, the gas will be pushed into the lung. That volume should be delivered into the lung in that time period. Then cycling is either volume cycling or time cycling. So you got choice in both, but the ventilator automatically adjusts it. Then volume assisted mode. So it is a ventilator assists the ventilation. Then you have got volume assist control mode. Then you have got intermittent mandatory ventilation IMV. Then you have got SIMV. These are volume controlled different modes, and absolutely controlled thing is a volume control ventilation. And we say mechanical, when we say we are ventilating a patient, CMV, that means it is a volume control mode. So it is commonly said. So if you put on a CMV, it means volume control It is not a pressure control. So specifically you will have to say pressure control is PC, pressure control. But the rest of this is volume assist control or intermittent mandatory ventilation and synchronized intermittent mandatory ventilation. They are assist modes. Later on you change them. But the policy should be, as soon as you put the patient on ventilator, you should be ready to put on a assist control mode also. So as soon as you can bring it back, it's better. Longer the period you ventilate the patient, the more will be the complications. So as soon as you achieve your target or near to target, you try to bring the patient, give the chance to the patient to breathe through it or should come back. So when we put the patient on a ventilator, it is under our control. We decide that we have to put the patient on a ventilator. We decide that these are the indications. Now the patient needs artificial ventilation. But when we take the patient off the ventilator, then the patient decides that I should come off the ventilator. It is the patient who tries to come off the ventilator, but we assist him by giving different modes to the patient. So it's very difficult to take the patient off the ventilator. It's very easy to put the patient on a ventilator. So all we keep in mind. Taking the patient off the ventilator is not an easy thing. Sometimes it might take weeks and sometimes it might take months also. So there are very big books people have written on that, how to discontinue the ventilation. Now pressure targeted modes are simple pressure control mode. It's mandatory when the patient is completely flaccid and patient is not breathing at all. We put them on a pressure control mode. And it is a certain time, under certain pressure, we are giving the gases into the lung, but target, we already know how much should be the tidal volume of this patient. To achieve that target, you control the pressure. You increase the pressure or decrease the pressure. Then cycling should be timed cycling in pressure control mode. Then there is a pressure assist control mode also, then pressure support mode also. So they are just modulating the thing as in the volume. It could be SIMV with pressure also. So it's both SIMV and pressure, SIMV with the volume also. Now these things actually, it will be better understood if you are standing in front of a ventilator and the patient is on a ventilator. It's easy to explain over there. It's only theoretical aspect. Now in volume control, known as the controlled mechanical ventilation also. In volume control, it is written on the panel of ventilator CMV. CMV means it is a volume controlled mechanical ventilation. Volume limited, volume cycled. Keep an eye on, when you are putting on a volume control, keep an eye on the peak inspiratory pressure. For example, you are giving 500 mils of a tidal volume, the ventilator will deliver it in the specified time, 500 into the lung. But how much pressure is required for the gases to be pushed into the lung? That is shown on the dial there, or digitally it is displaying what is the pressure to put this volume into the lung. That is called peak inspiratory pressure, PIP. Keep an eye on that. If you look at that PIP, you multiply with the 3 or 4 mil, that will be the compliance of the circuits. So that should be above the targeted tidal volume, so that the circuit should be accommodating that volume in itself. Right? So always keep in mind this compliance of the circuit is very important, and we don't consider it. Ordinarily, people don't consider who put them on ventilator. It's very important because you think you are giving this much volume, but it might not be going in that volume because some part of it is being accommodated in the circuit compliance. Then when you give volume control, you look at the peak inspiratory pressure. When you give pressure control, you adjust a certain pressure. The parameter you look is how much with this pressure. For example, you put on 15 centimeter water pressure. Now, how much the lungs volume is going into the lung? Because you know already this patient needs 500 of tidal volume, and you adjusted pressure of 15. Whether this 15 is enough to push this 500 or not, it means then you look at the volume. When you put them on a pressure control, you look at the volume. When you put them on volume control, you look at the pressure. This is very important because with the pressure control, you go on increasing or decreasing the pressure according to the response. What is the response? That is the volume. Whether we are getting targeted volume or not. So that's very important. It doesn't mean that we have put on 15 and you say, okay, we have started the ventilator. No, it's not like this. You should have calculated already, according to the body weight, how much is our targeted volume. Now, with this pressure, how much volume should be going in? We should achieve the target by increasing or decreasing the pressure, right? We are seeing every day. Now, pressure limited is the pressure cycled. Then keep an eye on the volume, which you develop to the patient. Then keep an eye on the plateau pressure also. Now, when you look at the PIP, you always look at the plateau pressure. What is the plateau pressure? It is the pressure at the alveoli at the end of inspiration. The inspirative cycle has gone into the lung at the end of inspiration. Then you look at the pressure. How much is the pressure now? It should be less than PIP. It should be less than peak inspiratory flow pressure, right? So peak inspiratory pressure should be greater than plateau pressure, but it should be greater than 30 centimeter. It should be less than 30 centimeter water. If you plateau pressure goes above 30 centimeter water, you should expect there is going to be pneumothorax to the patient. The patient lung will burst. Always keep an eye on the plateau pressure, particularly when you put the patient on a pressure control mode. The ventilator is showing already. If you go into the parameter, you look at the plateau pressure. Plateau pressure is very important. Plateau pressure is nothing. It is the pressure at the end of inspiration. It means it is a pressure which is present on the alveoli. Pressure at the alveoli at the end of inspiration. That's very important. So peak inspiratory pressure includes not only the resistance, which is lungs are offering resistance to the ventilator pushing. It also resistance of the circuit, resistance offered by the tube also. Bigger size diameter of the tube will offer very less resistance as compared to smaller size. According to Hagen-Parcelli law, if you increase the size, lumen diameter double, it will increase the 60-time flow. And if you decrease 50%, it will decrease the 16-time flow. So that according to, if it is a laminar flow, that's a Hagen-Parcelli law comes over there. But always keep an eye on plateau pressure. That's very important. And if there is danger, if you have to ventilate at a higher pressure than the dangerous level of plateau pressure, sometimes, so you have to put the prophylactically chest drains. Let the lung burst, but we want to have better oxygenation. Our target is oxygenation. Whenever we put the patient on a ventilator, if there is hypoxia, we have to improve the oxygen. Don't care about carbon dioxide. Carbon dioxide, sometimes we use permissive hypercapnia also in patient to achieve, to correct the hypoxia. Our target is hypoxia. So sometimes we induce hypercapnia up to 60 millimeter of mercury also, 65 millimeter of mercury also. This is one of the way of treating ARDS also. You induce hypercapnia. So target is always oxygenation. Now positive and expiratory pressure. So we put the patient on PEEP also. So first thing is you choose the mode, pressure control, volume control. You should have in your mind how much volume you require for this particular lung, whether you are giving through the volume control mode or whether you are giving through the pressure control mode. Then you should target how much should be the FiO2. And then according to that, and what should be the respiratory rate. That you have already adjusted now. Now we have to see whether you want to keep the positive pressure at the end of inspiration into the lungs or not. So most of the patients, when we ventilate them, we always put a PEEP, positive end expiratory pressure of 5 centimeter of water. Except there are few exceptions to this. First exception, if there is a central nervous system, if there is intracranial insult. Because if you keep the positive pressure into the thorax, that will reduce the pressure gradient between the higher upper part of the body and the intrathoracic venous pressure. If you reduce the pressure gradient, you will reduce the venous return from the upper part of the body, and that will increase the venous pressure in the cranium, and that will increase the intracranial pressure. That is dangerous. So we put 0 PEEP on that. But if it is required because of lung problem, if the lung is diseased and the lung needs to be kept expanded during at the end of inspiration to keep it open to avoid the atelectasis, if you put, for example, the PEEP of 5 centimeter water, you will have to raise the head more to neutralize, to have the gravitational effect, so that the pressure gradient should be kept constant or should be increased, so that there should be drainage of venous blood from the cranium to the superior vena cava. So we should be very careful putting the patient on a PEEP when there is an intracranial problem. Second thing is, we don't give initially PEEP to the patient who has got COPD, because there is already induced PEEP in those patients. Already there is chances of developing PEEP in the lung, because it is an expiratory obstruction. In COPD and asthma, there is expiratory obstruction. For expiratory obstruction, when we ventilate these patients, we always increase the expiratory phase. If there is an obstruction, whether it is inspiratory or expiratory, we can nullify the effect of obstruction by increasing the duration. If it is inspiratory obstruction, you increase the inspiratory period. If there is expiratory obstruction, we increase the expiratory phase, so that the gases should come out. There should not be remnant gases in the lung at the end of inspiration. So that will cause induction of PEEP inside. That is called PEEP-I or induced PEEP. So we always keep an eye when you are looking at the monitoring, while doing the monitoring of the ventilation. In the ventilator certainly indicates how much is PEEP-I, that how much is the PEEP left normally in the lung. So that if that is there, then we'll have to increase the expiratory phase to get rid of those gases also. Or specifically, when you put the patient on a PEEP, even ordinary patient also, you always keep an eye whether there is an induced PEEP or not. If there is an induced PEEP, it means there is some expiratory obstruction is there. Try to sort it out. Now, it's not a simple thing. You just press the button and you start ventilation. You will have to go according to the, along with the ventilator and along with the pathology of the patient also, and looking all the time on the result of ventilation also. It's a serious thing. You should always keep in mind you are going against the nature. When you are putting the patient on a ventilator, you are going with a natural way of breathing. It's a positive pressure breathing, and natural way is a negative pressure breathing. You are going against it. So there is bound to be some complication, which we discussed last time in the last lecture. Now, there are different types of PEEP also. So it's a big subject itself also. Prophylactically, PEEP we put 1 to 5 centimeter. If there is no contraindication for putting the patient on PEEP. So it will increase FRC, functional residual capacity, and it will decrease the shunting. If you open up the alveoli, keep the alveoli open, so there will be good, better oxygenation, better diffusion of the gases, because the functional residual capacity is increased, and the shunting effect will be gone. Shunting kahan pe hoti hai? Either if the blood is not coming there, or the blood is not coming in contact with the gases which are going there. So if the gases are going more than the circulation, so there will be dead space effect. If the blood is going more than the ventilation, or the ventilation is going less than the circulation or the perfusion, so then you will have a shunting effect. So these things will have to have ventilation perfusion ratio normalized. That's 0.8. It should be kept 0.8. Right. Then conventional PEEP is 5 to 20 centimeter water. Right. At PaO2 less than 60 or FiO2 greater than 60%. अगर आप इसमें दे रहे हैं, and you might have to go up to 20 centimeter water. Then high PEEP is 20 to 50 centimeter water. That's very high. We rarely use it in extreme hypoxia or resistant hypoxia, but always keep an eye on the plateau pressure and keep an eye on the pneumothorax. And always keep an eye on that because it might burst the lungs and you get the pneumothorax. And during ventilation, when there is a sudden increase in PIP or sudden drop of saturation, so always do the X-ray chest, clinically auscultate the chest and do the X-ray chest and rule out the sudden occurrence of pneumothorax. Try to rule it. There is no harm. If there is a pneumothorax, put the drain down. और नहीं है तो आपके पास BT सेट होगा, नीडल डालें और पानी में डुबो दें. We can save the life of the person. It's very easy. Now, then best PEEP or optimal PEEP is which suits the patient and you get the desired effect. That's the optimal PEEP for that particular patient. As I've told last time also, that when you are putting on a PEEP, for example, you have put the patient on a PEEP, the patient has got heart failure, a patient goes into pulmonary edema. If in spite of putting on a PEEP, the pulmonary edema does not clear up, rather it becomes worse. So always see whether there is pressure in the central venous pressure is higher than the pressure in the lymphatics. Lymphatics are not taking the flow because water is always drained from the basket, through the baskets of lymphatics in which the alveoli are lying. The water is only drained by the lymphatics. If the pressure in the lymphatic is greater than the central venous pressure, then they will be able to drain. If there is more pressure in the venous side, then lymphatics will not be able to drain. So if they are not able to drain, it means the water will still remain in the lung. So you reduce the PEEP. So you have to find out the optimum PEEP at which everything becomes clear. Now, advantages of PEEP. If you put the patient on a PEEP, it increases the functional residual capacity, it increases the compliance, it decreases the QS over QT, that is shunting effect. QS is the blood which is not coming in contact, and QT is the total blood which is passing through the lung. Then it will increase the PaO2, partial pressure of oxygen in the alveoli. It will also reduce the FiO2. When your PO2 is increased, accordingly you stop dropping the FiO2. So then it also reduces the cardiac output, total cardiac output, because the putting PEEP means you are putting the positive pressure to thorax. Putting positive pressure to thorax means you are decreasing the venous return. When you decrease the venous return, the cardiac output will be decreased automatically. So that you should keep in mind. But if the hemodynamics, heart is healthy, it can compensate very easily. But if there is disease heart, then you will have to strengthen the heart also. So, and you have to increase the venous return and strengthen the heart also by giving pressure agent and by giving the inotropic agent also. Disadvantage: decrease QT, it means cardiac output. And second thing is increased baron trauma. If you put a positive pressure into the thorax, some of the lungs alveoli can burst. It can cause pneumothorax. So whenever you put on a PEEP, should not be taken simply. One thing, when you are putting positive pressure, ventilation, that is creating pressure into the lung. On top of that, you put them on PEEP, it will increase the pressure on the alveoli. It can burst. As I told you last time, there are three traumas you keep in mind: barotrauma, volutrauma, and biotrauma. Three things. So these things do happen in every patient who is put on a ventilator. High PEEP or super PEEP. Avoid oxygen toxicity and then minimize the pressure gradient and minimize the QS over QT and maximize the oxygen delivery. That is the objective of giving them high PEEP. But always keep in mind if there is a pneumothorax or not. It's not a simple thing. When you have to use very high PEEP, although it will avoid the oxygen toxicity, although it will minimize the A gradient, although it will minimize the QS over QT, although it will maximize the oxygen delivery, but it can have a mechanical effect on the lung and cause pneumothorax. So it means in all these things, if you look at, it means you will have to be very vigilant when you have put the patient on a ventilator. One person should be present all the time, should not move from the patient. If the nurse has to move, then the other nurse should take over. So then she should have a break and the other person should be looking after. Never ever leave the patient who's on a ventilator alone. Don't leave the patient. Otherwise you will end up in complication. Optimal high PEEP. These are purely theoretical things, but PEEP means PEEP. So correlate with the lowest QSQT, change in the cardiac output, no change in the PVO2, no change in the oxygen gradient or AA gradient. Now, next thing is the BiPAP. As I told in the beginning, in the first lecture, what is a BiPAP? It is a pressure support type of thing. But the only condition for BiPAP is the patient should be breathing. That is the first requirement when you put them on a BiPAP. If the patient is breathing, then you put them on a BiPAP. But by BiPAP, during inspiration, we help them. धक्का लगाते हैं जैसे, we give them pressure support. And during expiration, this is called IPAP. During inspiration, you give the pressure to the patient. Under pressure, you get the adequate volume into the lung. So whenever you put them on a BiPAP, the first phase is IPAP. It means you give pressure during inspiration and you look at the volume. How much is being delivered to the lung? If the adequate volume is not satisfactory or less than what is required for this lung, then you increase the inspirative pressure. Now, during expiration, you put a PEEP on it. This is called CPAP. CPAP because patient is breathing on his own. So it is also again as required to keep it in. It will be 5 centimeter, 10 centimeter, 15 centimeter. You can go up to 20 centimeter also. So that lung should remain inflated. So this IPAP and EPAP, if you combine that, this is called BiPAP. So first condition is the patient should be breathing on its own. Then adjustment of FiO2, adjustment of tidal volume depends how much pressure you are going to give to the patient, right? So IPAP is called pressure support, 5 to 20 centimeter of water, and EPAP is CPAP, that is 5 to 10 centimeter of water. You can go up to 20 also. So this is important, and it's a very common word which is being used, BiPAP. In pulmonology, there are a lot of BiPAP apparatuses, but you have to see what there is indication or not, whether you're getting benefit out of it or not. So you will have to keep these parameters in your mind. How much oxygen is required to be given? How much should be the pressure to have the desired tidal volume? How much the pressure should be left in the lung at the end of inspiration? So you can only control the volume by looking at the IPAP, that under what pressure you are supporting the breath. The patient has to be breathing on its own. That's very important. If the patient cannot breathe spontaneously, don't put them on a BiPAP. There's no use putting them on BiPAP. Or patient is hyperventilating, there's no use putting them on BiPAP. Now, indications. When medical therapy fails, in ordinary pulmonology unit, patient gets tachypnea, hypoxemia, or respiratory acidosis, but the patient is breathing. So give them support with the BiPAP. Apparatus, छोटा सा apparatus you might have seen in our ICU also. So in respiratory therapy units or in pulmonology ward, there are BiPAPs lying there. So used in conjunction with bronchodilators and with the steroids and to delay the intubation and ventilation. So first thing you can use the BiPAP so that you can avoid the intubation and ventilation. Then it is a weaning protocol also. The patient has been on a ventilator and you want to extubate and put on the BiPAP, that's very good. It's a weaning mode. Then obstructive sleep apnea. So some people who obstruct while they're lying at night, to help them, put them on a BiPAP apparatus. Yeah, we have got MNAs who are on a BiPAP and they go and scream in the assembly also. Then at night they put the BiPAP on their face and they're living like this. हमारे पास भी आते हैं कभी कभी. Now, this is about BiPAP. The things which I have told you now, ventilation and normal ventilation or the ventilation and what should be the mode and the thing, this needs to be seen in a ventilator. Then you will remember it more. It's all theoretical aspect I'm telling you, but these are the practical points which we keep in our mind, right? This is how we put them on a ventilator.